Is Jay Brown. I'm chair of the teaching committee in the Public Health Coalition. And I want to thank you all for joining today. Today is the first seminar of our fall 2025 seminar series. We're very excited to be back to share with our community the exciting work being done in the name of public health across campus and beyond. Today we have two researchers who I'm very excited to hear from. Beyond their shared interest in addressing disparities in cervical cancer research, screening, diagnosis, and treatment, and indeed cancer more broadly, both presenters are also affiliated faculty of the Texas Institute for Sexual and Gender Minority Health Research, among others. I'm thrilled that you all have joined us and believe you're in for quite an interesting hour. First up to present today, Jenny Spencer. Dr. Jenny Spencer employs econometric and decision science to improve health equity in cancer screening and prevention, particularly cervical, breast, and colorectal cancers. Her projects include exploring uptake of HPV vaccination and cervical cancer screening, modeling approaches to improve colorectal cancer screening in Texas, and studying LGBTQ plus disparities in breast and cervical cancer screening. Before I hand things over to Jenny, I'd like to encourage everyone, if you have any questions, just type them into the chat box. We'll try to get to them after our presenters speak. You can also just wait till the end of the presentation. We'll give about 5 to 10 minutes for folks to ask any questions that they have. So without further ado, please welcome Dr. Jenny Spencer.
Fabulous. Well, hi everyone. It's so great to be here. I assume everybody can see my slides and someone will scream if they look bad. But as was said, my name is Jenny Spencer. I'm in pop health here at the Dell Medical School, and really excited to talk about some of my work today around cervical and breast cancer screening. I have no conflicts of interest. So I think about my work as sitting kind of at the intersection of three different areas of work, cancer prevention and control, health equity, and simulation modeling. The cancers that work around include multiple, so cervical, breast, and colorectal, mostly right now. Health equity populations that I work with include multiple, so I will talk about work in LGBTQ women, but also have done work across socioeconomic, racial disparities, and other kind of underserved populations. And then simulation modeling is really a method to address these questions. And so I'm happy to chat if folks have interests in any of those areas, and especially if folks have interest at the intersection of those areas about any piece of that. So the work I'm going to talk about today focuses on LGBTQ women, so those who identify as lesbian, gay, bisexual, or queer, and who we know from multiple studies may be less likely to engage in a variety of preventive care services. This includes cervical and breast cancer screening. The reason for this is multifactorial and includes both issues of access to care and issues of trust in providers or negative experiences in the healthcare system. But generally, we know that LGBTQ women are less likely to engage in care, and previous studies have kind of shown some evidence that this includes cancer screening. The goal here was to really focus on differences across LGBTQ subgroups. This group often gets kind of chunked into one, even though there's a lot of diversity within these populations. And then to also look at some differences across data sources. And I'll pause here with the disclaimer that I am looking at LGBTQ women because that is who is included in the data. Trans populations who are eligible for cervical and breast cancer screening are also incredibly important and incredibly underserved. And future work should really investigate that in more detail. But the surveys that I'm using asked really poor questions about gender and didn't assess it very well. And so I will be sticking strictly to LGBTQ populations, not because the larger groups are not important, but just because that is who I had data on. So our goal here was to compare LGBTQ disparities in up-to-date cancer screening use, in cancer risk factors, and in cancer access factors across three national surveys in the United States. The three surveys we ended up using for this study included the Behavioral Risk Factor Surveillance Survey. So this is a large nationally representative survey conducted in all 50 states and DC. They assess cancer screening every even numbered year. They included a sexual orientation and actually gender identity. They're the one survey that did include this module, but it was an optional module, so it was included by 30 states in 2018 and by 32 states in 2020. So we're only examining those states in this analysis. The National Health Interview Survey is another large nationally representative survey that assesses a variety of health behaviors, healthcare access measures, and other pieces of health information. They included sexual orientation module for everyone in 2019 and 2021, and also assessed cancer screening. And then finally, the National Survey of Family Growth is a large nationally representative survey. It's really focused on reproductive health. So it's a younger group than the other two surveys, which are 18 and older. The National Survey of Family Growth is actually 15 to 49-year-olds, and it assesses a variety of reproductive health questions, but does include questions on cervical cancer screening. So we'll use it in our cervical cancer analysis, but not in our breast cancer analysis. We started off thinking we were going to do this analysis in the National Health Interview Survey, and then we realized it didn't have all the questions that we were interested in, and I was working on the other two surveys for other projects and realized they had some really interesting questions, and so we ended up pooling all of these surveys together using an individual participant data meta-analysis, which we can do because we have the data from each of these surveys. We know the sampling weights in each of these surveys, and they're roughly the same sampling frame. So we're able to combine these together and produce survey-weighted prevalence of screening risk and access factors. So I'll start with our cervical cancer screening results. The first thing I want to point out is that these are very differently sized surveys. So even though we were only using a subset of states, we ended up with 120,000 participants from the BRFIS survey, the largest by far. The National Health Interview Survey included around 20,000 women, and the National Survey of Family Growth, because it's such an intensive survey, surveys fewer people, and we ended up with around 5,000 women. Both the BRFIS and NHIS had around the same proportion reporting LGBTQ identity, so 6 in the NHIS and 8 in the BRFIS. The National Survey of Family Growth had the largest percentage at 12.5. This is partially because it's just a younger sample, but also partially something about their sampling frame may have just gotten a higher proportion of LGBTQ participants. This is our primary outcome in our meta-analysis. So here, the dashed line at 1 shows no difference. Anything lower than 1 shows lower screening use for LGBTQ women relative to straight women. You can see the results from each of the surveys individually, which all show lower screening use for LGBTQ women for cervical cancer screening. And then the pooled result, which combines all of these. Our pooled relative risk is 0.91, so 9% lower screening in LGBTQ versus straight women overall. We find that this varies by age with the largest gap at the youngest ages in the 21 to 29-year-olds, a significant gap in the 30 to 39-year-olds, but the gap seems to close in both significance and magnitude in age 40 and above. When we adjust for the fact that there's different age distribution in our LGBTQ and straight samples, we still find overall a significant difference in cervical cancer screening use. And then we were able to look at a couple subgroups of interest. So we found comparing LGBTQ versus straight Hispanic women that there was no difference in screening use. But comparing LGBTQ non-white women, we found lower screening use relative to straight non-white women. We also looked within LGBTQ identity categories and found that lesbian women and bisexual women both had a significantly lower screening relative to straight women, but that this was 0.9 for lesbian women and 0.94 for bisexual women. So maybe a slightly larger gap for the lesbian women in this sample. We also looked at some differences in risk factors and found that these kind of went in both directions. So, LGBTQ women were more likely to report having had an HPV vaccine, which is good and protective against cervical cancer, but also more likely to report being a current or former smoker, and more likely overall to report a higher number of male sexual partners, which we categorized as more than 15 lifetime partners. Um, this was importantly different within sexual identity groups. Lesbian women had slightly lower numbers of male partners, but not tremendously lower numbers than straight women. And then bisexual women overall had higher numbers. We also looked at differences in care access and found LGBTQ women may be slightly more likely to be uninsured, but much more likely to report no wellness visit in the past year, and nearly twice as likely to report that they had a difficulty paying for care across all three of those surveys. So, overall, in our cervical cancer analysis, we find small but significant differences that are largest at youngest ages. We find pretty consistent differences in care access for LGBTQ women and suggest that addressing these access differences might not only help improve cervical cancer screening, but also improve other areas where LGBTQ women are less likely to receive preventive care services. We find both positive and negative differences in cervical cancer risk factors. Some of our future work that I'll talk about at the end aims to help us sort out kind of the direction of these risk factors and how much each of them may be contributing overall to disparities in cancer incidence. And then we find there's some really important differences by sexual identity. So in the cervical cancer analysis, we find bisexual women report worse access pretty consistently, but have higher screening than lesbian women, only slightly so. But both groups seem to have lower screening, even though bisexual women have worse access, which may suggest roles both of access to care and of risk perception, where other studies have shown lesbian women may perceive themselves to need cervical cancer screening less. And providers may perceive women who are currently in a same sex relationship to need screening less, sort of regardless of prior sexual relationships that may actually be more likely to dictate their risk. Okay, so I'm going to move on to the breast cancer analysis, and then I'll do questions about both at the end. Our breast cancer analysis was really similarly structured, but only used two of the surveys because we're looking at older groups of people, women ages 50 to 74. And then overall, the proportion reporting an LGBTQ identity was lower because this is an older sample where we know individuals are less likely to report an LGBTQ identity. Our meta-analysis is set up the same, so lower suggests lower screening in LGBTQ women, and we find overall the pooled analysis and the BRFIS show lower use of breast cancer screening. The NHIS is slightly lower, but has a wide confidence interval because it's a fairly small sample. The pooled relative risk is 0.95. We see similar age trends with the larger differences at younger ages. Importantly, this 40 to 49-year-old group was not strongly recommended to have breast cancer screening during this time period, but it was left as a shared decision making by the US Preventive Services Task Force. And this is really where we see the biggest difference is in this 40 to 49-year-old group. And then the 50 plus group, we see that same kind of dose response almost with age getting smaller and smaller as age gets older. We did not include the 40 to 49-year-olds in the other analyses because they weren't strongly recommended at the time, but adjusting for age overall, we still see a significant difference. In our Hispanic and non-white subgroup analyses, we do not find any significant differences, although non-white is overall lower, but there's wide confidence intervals. And then importantly, when we look at differences by sexual identity, we find that lesbian women have no difference in breast cancer screening, with all three surveys showing relative risks very close to 1. And bisexual women have lower risk of breast cancer screening in both surveys and in the pooled analysis, with a relative risk of 0.91. So this difference in the LGBTQ group overall is really driven by bisexual and queer women having much lower screening. Our risk differences for breast cancer screening, we included drinking, which is associated with breast cancer, and found LGBTQ women had slightly higher risk of both binge drinking and heavy drinking, were more likely to report being a current or former smoker, and were more likely to have a BMI over 30, which is also considered a breast cancer risk factor. And then overall, we found access differences were much less pronounced in this older cohort, but some differences in uninsurance, very small there. But when we broke this out further by sexual identity group, we found that bisexual women were more likely to report being uninsured and were more likely to report a difficulty paying for care, even in this older cohort than straight women. We found the reverse for drinking. We found lesbian women were actually more likely to report both binge drinking and heavy drinking than straight women, but there was no difference for bisexual women in either measure. So our conclusions in the breast cancer analysis are, again, we find these small but significant differences in breast cancer screening, but they seem really driven by differences in bisexual and queer women. There are smaller differences in access to care, but it may be important to address these, particularly for bisexual women who may be more likely to have difficulty paying for care and more likely to be uninsured. We find some differences in the important breast cancer risk factors that are importantly different within those subgroups. So higher drinking among lesbian but not bisexual women, higher BMI, and then higher smoking in both groups. And then lastly, I want to point out that we do find some differences across these surveys that we think are worth considering a little further. There's differences in sample size, so we find the confidence intervals for the NHAS were pretty large, but also that it consistently reported smaller disparities in each of those measures as compared to the BRFIS. So understanding how and why those differences exist, which may be related to which states the BRFIS is including for those years, or how they're reaching out to populations, will be important to consider. Okay, so a little preview of where we are moving next with this work. As I said at the beginning, I'm really interested in simulation modeling. And so this project is, this is kind of early data gathering for a simulation modeling project. So we're working through the process of creating a simulation model right now of cervical cancer. The next step will be of breast cancer. This really involves designing out what a model should look like based on our clinical understanding of these diseases, identifying the relevant input data, which this was part of, building out and coding the model, which is what we're doing now, calibrating and validating the model to ensure that it makes sense and fits well to the data that we have, and then kind of running the specific analyses to make the comparisons that we're interested in. This is a schematic of what a cervical cancer model looks like very simply, looking at transitions between acquiring HPV, HPV progressing into detectable precancerous states, cancerous states, and then finally deaths from cancer. We can add screening into this to show the relationship between cancer screening and early detection of cancer or early detection of precancer. And then we can add in the risk factors that we know influence some of these transitions, and we can modify these factors for sexual identity and incorporate these data we've collected on LGBTQ women to try to understand the potential differences between LGBTQ and straight women, giving our understanding of their risk and screening in some of these outcomes like cancer and cancer deaths, which we can't directly measure because no registries collect data on sexual identity. So we can use this model to really better understand how to conceptualize all of these differences that we've described and get a range of what kind of impact they may be having on cancer incidence in this population. Okay, so I want to thank the fabulous team of folks that I'm working with. This is part of my Career Development Award, and I have an amazing team of mentors, and also Hanwen Zhang, who's on the call, who's a PhD student in pharmacy that led the breast cancer analysis I talked through. And I'm happy to take any questions. Both of the cervical cancer and breast cancer paper are published if you want to read them in more detail. Uh, Happy to answer any questions. Yeah, Elizabeth.
That was great. Thanks. Um, are these lower screening rates specific to breast and cervical cancer, or is this just a general phenomenon about cancer screening in general, or also just a general phenomenon about preventive health care, like
Um,
getting, vaccines, flu vaccines, or
okay, great
sorry.
question. Yeah, yes and no. So in some ways, there are studies suggesting LGBTQ women are just less likely to go to a doctor at all. There's all kinds of services they may be less likely to receive, but it's not as consistent. There are certain services that don't seem to have much of a difference, or as we found, like lesbian women less likely to get cervical cancer screening, but no less likely to get breast cancer screening. So there's definitely some degree of either personal preference or provider preference or something else kind of specific to those services playing in. I suspect there may also be differences in other cancer screenings. Um, Colorectal is the other one that I think we'd be interested in. Um, but I think some of the many factors that go into it are related to the cervical and breast cancer nature of it and sort of perceptions around that as queer women being less willing to get those screenings or feeling less like you need those
Right, so
screenings.
having to do with the target organs that are affected.
So I think
And
it could be, it's related to both some overall barriers and some target organs specific.
thanks.
Jenny, that was great. I have a question about some of the research questions that you hope to
Mhm.
address with those models. So what are the first sort of questions that you're thinking about once you get your model up and running and validated?
So I think our first question is really looking at whether we would project a difference in cervical cancer incidence or and then breast cancer incidence based on these or breast cancer mortality based on these differences in screening and differences in risk factor. And we don't have great causal estimates for every risk factor, but we can look across sort of the range of what it could be from other analyses and say, well, if smoking is really causally related in this way, then this might be the outcome. And if it's not, then this might be the outcome. But we have a good understanding of the causal relationship between screening and cancer stage. So that's easy to put in to try to understand, but then also contextualizing in some of these risk factors. I think it really is not coming up with a definitive yes, there is or no, there isn't a difference in cancer incidence, but like how big or small could it be based on our understanding of these is really the first question, trying to understand whether there are differences. And then the second question is, how would we best address them? Is it through improving screening or is it through reducing some of these other risk factors where sort of would make the biggest difference in a projected estimate?
That's great. I look forward to seeing those results.
Thanks. I look forward to having them. Jay.
Great presentation, Jenny. Just yesterday in class, we were talking about the attribution theory and how we go about attributing causes to events. And one of the things we took a look at was how screening rates was affected by stereotyping. And one of the specific studies mentioned how obese women have lower cervical
Mm.
and breast cancer screening rates because of that fear of discrimination. And I was wondering if you found any of that same thing where, worry about discrimination in this population may have impacted those screening rates.
Yeah, I mean, I think that's really important. We were hoping to have some kinds of questions about provider trust or comfort or in these analyses, and we really don't have good measures of it. I'm back into the NSFG now, looking at some data that they have some questions that are like, why haven't you gone to a provider, that start to get it like, I don't trust providers versus I can't pay versus. So,
Right.
I think we want to understand some of those pieces more. Qualitative data has certainly suggested that comfort with provider and provider trust may be a reason. And then I think, the same stereotyping on the other side, where, as I mentioned before, a provider who sees a person in a same-sex relationship may say, women in same-sex relationships are at low risk for HPV. They may not need a cervical cancer screening.
Right.
But we know from lots of scientific work and especially simulation modeling that actually your past partners going much further back than a current partner is what puts you at risk for cervical cancer, unlike other STDs, which may be much more kind of current partner related. And
Yeah.
so an accumulation of risk, and considering like that, particularly for, bisexual women or for lesbian women who have a history of male partners, it may be kind of on both sides, some issues, fear of stereotyping and then the actuality of it. Eliza.
Yeah, I'm kind of riffing on that same topic. This is super, super interesting because I don't think we often ask about, well, some, in medical school where we were initially, I think a long time ago, maybe even still taught to, ask about lifetime sexual partners, but just as like a broad number. And I think that's kind of fallen out of favor. But I think you're right that there is a supposition that these sexual orientations are kind of set in stone and don't fluctuate, or like necessarily mean that if somebody currently identifies as a lesbian, they've never had sex with a man. And so I think your data about how, I think you said that there wasn't a big difference really between the number of male prior sexual partners between lesbians and bisexual women and even straight women. Was that right? That
Yeah, so
it was
bisexual
around the
women
same number?
are
Hmm.
overall more, and
Uh-huh.
then lesbian women, there's a higher number with 0,
Uh-huh.
but then that distribution, that number with like more than 15 is the
Uh-huh.
same as for straight women. It's like the distribution
Yeah,
is
yeah. Uh-huh.
different, but
Yeah.
it's
I
kind
think
of
that's a
yeah.
key. Yeah, I think that's a key point. And when I was thinking of is, it would be interesting to see if those kinds of questions about, specifically related to cervical cancer risk, how many male lifetime sexual partners have you had, or something like that, could be codified in an EMR or an intake so that it kind of lowers the barrier for physicians to think about. I don't know. I guess
Well,
it's
okay.
also an across the board recommendation for screening, but yeah.
I was going to say
Anyway,
screening recommendations,
yeah,
don't vary
yeah.
by that if you've ever
Yes,
had,
that's
any
true.
male sexual partner. And so I think maybe the
It's
lesson
more the
is
concept. Uh-huh.
rather than try to titrate screening
Yes,
risk,
yes.
like just screen everybody
Yep,
the
yep.
appropriate amount, and don't, lower the what you think the risk
Right,
of,
right.
needing a screening is based on someone's physical appearance, as Jay was saying, or partners, or any of those elements. But I think it is, yeah, I mean, it's
Yeah.
easy to say like there's a lot of things that need to be done and you have to prioritize, and so maybe sometimes people prioritize that lower, when they shouldn't.
Right. Thanks so much, Jenny.
Yeah, thanks all.
All right, let's go into our second speaker. So, our next speaker is Jessica Calderón-Mora, and Dr. Calderon earned her master's and doctoral degrees from the UTHealth School of Public Health, focusing on health promotion and behavioral sciences, with an emphasis on health disparities and cancer prevention within the Latinx community, particularly in cervical cancer screening and HPV vaccination. Calderon-Mora's recent work explores HPV self-sampling and coordinated expansion of cervical cancer prevention resources across Texas. Please welcome Dr. Calderón-Mora.
Thank you all. Hopefully you all can see the correct slides. Yes, does it look okay? Awesome. All right. I am so honored to be here this morning, and especially presenting with my colleague and friend Jenny. And so I'm going to kind of segue into something that Jenny mentioned during her talk was the access to cervical cancer screening. And so what I'm going to talk about is kind of an alternative to what we traditionally think of with cervical cancer screening. So I'm going to be focusing on at-home HPV self-collection, which is an alternative for underscreened and hard-to-reach populations. So just to give you an idea of what I will be talking about today, first I'm going to give some background on cervical cancer incidence and screening rates. I will also be talking about barriers to cervical cancer screening among Latinas, a little bit about the human papillomavirus or HPV, and then really going into what this study is doing and some preliminary data so far on our project. So, although nationwide we have seen a significant decline in cervical cancer incidence and mortality, health disparity still persists among Latinas. So we still see higher rates among Latinas, and this is especially true along the US-Mexico border. So as you can see here in the table in purple, when we look at incidence rates, it's quite a bit higher for Latinas in Texas at 11.6 per 100,000 versus 7.7 per 100,000 for non-Hispanic white women across the US. And then when we look at mortality, we also see it slightly higher among Latinas in Texas at 3.3 versus 2.2 for non-Hispanic white women across the nation. Then when we're looking at cervical cancer screening rates, we know that cervical cancer screening is effective at prevention and early detection of cervical cancer, but we're not seeing great rates, especially in the Latina population. So in a paper that Jenny published a couple years back, we saw that this is indeed true, that Hispanic women have a lower rate. So those that have ever had a PAP is at 79.3% for Latinas versus over 90% for non-Hispanic white women. And then those that are up to date with the screening guidelines, we see again, it's slightly lower for Latina women at 71.6% versus 74.6% for non-Hispanic white women. So kind of going into some barriers for cervical cancer screening among Latinas, we know that the top one is related to social determinants of health. So this is lack of access to healthcare, which is usually caused by other non-medical drivers of health, right? So lack of transportation, inability to get away from work, the financial barriers, lack of finding somebody to care for young children or an older adult if the woman is a caregiver. We also see issues of acculturation that come into play as a barrier. And this we see mostly through linguistic barriers with providers, so not being able to communicate with the provider because they don't speak your language. Also, we see a lot of cross-border use of healthcare. This is especially evident along the Texas-Mexico border, where individuals are seeking some healthcare in Mexico and then coming back to the US for others. So this prevents a lack of continuity in healthcare and especially exchange of medical records across the border. And then finally, there are some psychosocial and cultural factors that come in as barriers for cervical cancer screening, one of them being due to the taboo nature of the screening. So this can be due to individuals thinking that the only individual that should be seeing a woman's private area is their significant other. Nobody else should be doing that. Also, in the Latino culture, we see that women are the primary caregiver. You should always put your family's health as your priority, and so they're not really thinking about their own health. So now switching gears a little bit to human papillomavirus. We do know now for sure that HPV does cause cervical cancer. And in fact, we know that HPV DNA is found in over 90% of cervical cancer cases. Now, when looking at different types of screening, we know that the HPV test is better than the cytology-based PAP at detecting precancerous and high-grade lesions. So we have seen some movement in the direction of really focusing on HPV testing as the preferred method. And I'll be talking about a few things that we've seen over the past couple years that are slowly getting us to that being written into the guidelines as well. So last year, in May, the FDA did expand approvals for two tests that detect cancer-causing types of HPV in the cervix. And under these, people can now be offered the option to collect a vaginal sample themselves for HPV testing if they cannot or do not want to have a pelvic exam. Now, the catch here is that the collection needs to be done in a healthcare setting. So this can be primary care offices, an urgent care setting, pharmacies, and mobile clinics. So that is the one caveat for that FDA approval. Then in May of this year, we saw the FDA approval of the Teal Wand, and this is for in-home use. And so this is getting us a little bit closer to where we want to be. However, there are a lot of cost barriers to this specific device. It's only available in a few states and they cannot serve Medicaid patients. So it's not easily accessible to those that we're actually trying to screen, right? And so the company does hope to have more nationwide availability by the end of next year, but we shall see how that goes. So now related to what we're seeing regarding screening guidelines, the current recommendations according to the U.S. Preventive Services Task Force that have been in place since 2018 dictate that screening starts at age 21 and that those 21 to 29 receive a cytology-based PEP every 3 years. And then for women 30 to 65, they have a few options. So they can get the PEP test every 3 years. They can have co-testing, so the PAP test plus an HPV test in clinic every 5 years, or just the primary HPV testing every 5 years. So last December, the U.S. Preventive Services Task Force put out a draft of updated guidelines, which are shown here on the slide, and they were made open for public comment through about January of this year. And we were really hoping to see these finalized by spring, but I'm going to cross my fingers that we see some finalization by end of this calendar year. But I kind of wanted to summarize the changes that we're looking at. So first is that primary HPV testing alone is going to be the preferred screening modality for cervical cancer. And this is really starting to align with other recommendations we're seeing, namely by the American Cancer Society. Next is that HPV testing can be done with samples collected by providers or the patient with no specific preference for either. So this is where it's looking a little bit different from other guidelines that still prefer that clinician collected sample. And the USPSTF has really decided to say, you know what, they're essentially equal, which is really more aligned with the data we're seeing in that patient collected or clinician collected really do have similar sensitivity and specificity. Also, these guidelines will be saying that primary HPV testing with both patient and provider collected samples can be done every 5 years. And there's not really a specification where it needs to be done. It does use the term patient collected, but right now it's still going off of FDA approval, so that would need to be under the purview of a healthcare setting. And then finally, PAP and HPV co-testing will be seen as acceptable, but the preferred test will be the primary HPV testing. So we shall see when this all goes through, but we are seeing slow movement working towards more of this patient-collected sampling. So kind of going back to those barriers that I mentioned, how are we going to address this, right? So this is kind of what I started thinking about, is that we want to address this in our community, especially in underserved and underscreened areas. And so we're looking at self-collection as an alternative to clinician-collected samples. So it's really an option for people that can't take time off of work, can't get to the clinic, see it as taboo, want to be doing this in a private area. And really, we've seen the success of self-sampling in diverse populations. However, most of this research has been done outside of the United States, and it's usually among high-risk women. So it's among women that have already had the PAP, and it's an abnormal result. So we're really trying to move the needle a little bit closer up to when we see these average risk women in a primary care setting. So for all of these reasons is how Unidos contra el VPH came to be, which is United Against HPV. And so this is our 5-year grant funded by the Cancer Prevention and Research Institute of Texas, or CPRIT, through their academic research arm. It's been funded since February of 2024, and we have had some great successes so far that I will share in just a minute. But first, kind of wanted to lay the groundwork for where this work is happening. So this work is actually happening in El Paso, Texas, which is my hometown. We are partnering with the federally qualified health center out there. So to give you an idea of El Paso, we are one of the 32 designated Texas-Mexico border counties with over 865,000 individuals. We are majority Latino at 83%, with about 19% living in poverty, about 22% that are uninsured. Only about a quarter of the population has a college education, and a good chunk of the population speak a language other than English at home, which more than likely is Spanish. Now, when looking at our partnering FQHC, Project Vida, they have 5 clinic locations throughout the area. They serve over 13,400 patients. They see about 40% of patients that are uninsured, and they're up to date with cervical cancer screening rate is under 50%. So we thought, okay, this is a great area to look at. They are wonderful partners, and we want to see how we can help them increase that rate. So to give you an idea of what our overall goal is, the goal is really to see which method will help increase cervical cancer screening rates in a primary care setting. So we're doing this through 2 specific aims. First is to compare the effectiveness of 3 techniques on that completion rate. So I do want to emphasize that we're not looking at accuracy. We're not looking at specificity and sensitivity at this point. There's plenty of literature out there to show that it is equivalent, more so the swab than the urine, but it is equivalent to clinician collected samples. So we're randomizing women to see which group will have the highest completion rate. We are also administering pre and post surveys that are grounded in behavioral theory to look at changes in knowledge of HPV and cervical cancer, looking at beliefs and attitudes surrounding screening, and then preference and self-collection methods. So, who are we enrolling in our study? We are enrolling individuals with the cervix who are 30 to 65 years of age. They have not had a PAP in the past 3 years, and they're a current patient of Project Vida. So this means that they've gone in for another reason, an acute illness within the past 12 months. And we will be recruiting 735 individuals with about 245 per group. All participants will receive that pre and post survey regardless of whether or not they complete the sample. So, how this is done, we have an amazing senior outreach and recruitment coordinator who is the individual that recruits and enrolls all of the participants. So she determines their eligibility, she consents them and has them complete all of the intake forms. She also administers the pre-survey. She then randomizes the woman to one of the 3 groups. So that's looking at in-home self-collection by urine testing, in-home self-collection by cervico-vaginal swab, or our control group, which is in-clinic co-testing, so a PAP and a clinician-collected HPV sample. So once they complete that pre-survey, they get and they're randomized. They get education on what is HPV, what is cervical cancer, and then they get very detailed instructions on how to do their sample or they get help making the appointment if they are randomized to the control group. Now, I want to emphasize all of this is done in English and Spanish, and most of our materials are pictorial to accommodate to various health literacy levels. So once they get their sample, if they're doing an in-home sample, they get everything to mail that sample back. So they get their FedEx box and all of the instructions, and we do everything we can to help them with that because it has to be shipped overnight to our lab in Washington State. And El Paso is a very sunny city and very hot. And so we want to make sure that those samples aren't sitting outside for a long time. So it is a lot of work on the staff to make sure those samples get picked up in a timely manner. Now, either they complete the sample or it's been several weeks, they get a call back. They do get reminder calls in between as well, but they get called back to do a post survey because regardless of whether they've completed the sampling or the testing or not, we want to see if their knowledge changed and perhaps what was a barrier to finishing that sampling. So they do that post survey. For those that have gotten an in-home option, we give them their results. We are provided with the pathology report that specifically dictates if they tested positive, what strain it is for. It tests for 14 strains. We also help them with any follow-up testing. So the chief scientific officer of the lab we're working with said, you know what? We do not have any validation of the urine sample in our lab. We're going to ask that you highly, highly recommend that all the patients with that are randomized to the urine testing arm go in for co-testing. And so to be saved for another conversation, but what we're seeing is something interesting where a lot of the urine samples coming back positive or coming back negative on the PAP and the HPV test in office. So we're doing another little study to kind of do our own validation of that. But okay, so I just wanted to show you all kind of the instructions that they're getting. I want to give a shout out to the UT Center for Health Communication for helping us develop our logo, as well as these wonderful instructions that we use. These are for our vaginal swab. So all the way from washing their hands to how they need to close that tube to get it in the FedEx box. And then we have the same for our urine test. So these are heavily pictorial, not too many words on each of the sheets that we give them. So what have we found so far? So we launched our recruitment in January, end of January of this year. We have recruited over 100 women, but the data shown here is up to when we had that nice round number of 100. We are seeing a mean age of about 50 years old. We're seeing about a third of our population has high school completed, and then another third has some college. With regards to primary health insurance, 43% are uninsured. I do want to note that we are not we're not basically paying for the in-clinic testing if they're randomized to that arm. However, they are usually with other programs within the clinic where they don't have to pay, or we're leveraging other programs in El Paso that do pay for those services. So we do want to make sure they're not having to pay for that and that that's not a barrier. With regards to country of birth, 59% are born in Mexico. The majority have, or over half rather, have lived in the US for over 25 years. Reflective of the community, we see the majority are Latino. About 54% have Spanish as their preferred language. And then 56% have high acculturation, which kind of ties back to that close to same percentage having resided in the US for a couple of decades. So this is my favorite part of all. So what I hypothesized is that those in the urine sample arm would have the highest completion rate, and thus far, that is proving true. So we are at a 97% completion rate for urine, a little bit further behind, but not too far. At 88% is the swab, and then we see our control group at 35%. So, we have the clinic does do reminders for that group. And if they were ever to call back and say, hey, we didn't get to do it, we want to get back in the program, we will help them reschedule that appointment. So this is not to say that we just let people fall through the cracks. This is even with the clinic really kind of pushing and reminding them. And then looking at our survey, we do, for the most part, see all of the groups, all of the study arms for our psychosocial factors moving in the direction that we hope they would. So this is looking at the pretest compared to or rather the change score from the post-test to the pretest. We do see an increase in knowledge across the board, as well as susceptibility and severity. We see decreased barriers, except for in our control group, but that's a small sample. And then overall, that increase in benefits and self-efficacy. So really excited to see these as well. We do still have 3.5 years left in our program, so stay tuned. I do hope to have some even more exciting data once we continue with our recruitment. And I do want to take a moment to acknowledge my wonderful team. So Nicole Clues is Assistant Director for Cancer Prevention and Research. Yaneth Rivera is our Project Manager. And Mariah Alvarez Ramirez is our Senior Outreach and Recruitment Coordinator, who is the face of the program at the clinics. And as you can see, even by her picture, she always has a smiling face. So we're very lucky to have her on board and bringing in all these participants. So that is pretty much it. I'm happy to take any questions, and thank you all for your time. Eliza, did I see you had a question?
Yeah, thank you. This is such an exciting topic, and you've already done so much work on it. It's really, really cool. And it seems like just getting this out to people is going to be a huge benefit if we can get it out to homes. My question was, in this clinic setting where you were working, you mentioned, I think it was like 40% of the patients are uninsured. And what is their access to OB/GYN follow-up for colposcopy once the swab is positive? I know, clinically we have a big issue with either people being insured and then losing their insurance, and not being able to get to that specialist, or just being uninsured and outside, our MAP catchment area. And it poses a huge problem because they have a diagnosis with nowhere to go. So I think that'll just be something logistically we have to work through. So I wanted to hear like how y'all navigated that.
Yeah, most definitely. So for colposcopy, they are referred out. Most of them are referred out to Texas Tech in El Paso. And fortunately, Dr. Shokar, who's also on the call, and myself, we're co-program directors for a cervical cancer screening program out there that has been able to continue. So we kind of leverage them because they will pay for everything up to being diagnosed. So we kind of are able to funnel that through them as well. But also, I have to say our clinic is pretty amazing at covering those costs, figuring out programs that they can apply to cover those costs as well. And the clinic manager there is amazing because we do ask her for colposcopy information, including if they attended, that kind of thing. So we do kind of have that piece figured out. And then through that other program, they have a treatment pathway. So we kind of, are lucky in that sense that it's an area that we've built those relationships with, but it is still difficult. Yeah.
Hey, if there aren't any other questions, I want to thank both Jenny and Jessica for their time. Excellent presentations today. Kyle, do you want to take us out?
Yeah, sure. Thanks so much for joining us, everybody. Our next seminar is going to be on October 9th. We're going to have Melissa Harrell presenting some data. So all of that can be found on the School of Human Ecology's website's events page. But I'll also be sending an email around with our full slate of events coming up shortly. Thanks so much, everybody.
Thanks
Have a great
all.
day.
Thank you. Have a good day.
Bye.